talk about some endocarditis, pericarditis, and some of our valvular disease. So we got our valves. We have 4 heart valves. We have our pulmonic valve, our pulmonary valve, and our aortic valve. And so these are called semi-lunar valves because they look like a quarter of or part of like the moon. And they each have 3. And then we have our tricuspid valve, which is 3, that's why it's tricuspid, on the right side of our heart, and our mitral or our bicuspid valve, because it's got 2 over here, and that lives in between our left atria and ventricle. Our mitral, bicuspid, and our tricuspid valve are also connected to Purkinje fibers, which connect to our papillary muscles. So not only do they open with our heart contraction, right, but in systole, these papillary muscles also are going to close our valves. And then in diastole, since this is connected, it's going to pull the valve open so that we can have filling into our ventricles in diastole. Valve conditions is called regurgitation. So regurgitation is when we have our heart valve, okay, and it doesn't close all the way. Okay, so if it doesn't close all the way, during systole, we're going to have blood sloshing back up into where it came from. So in our mitral regurg, right, we're going to have blood sloughing back into our left atria instead of from our left ventricle out into our aorta, which is going to decrease our cardiac output. Fibrosis of the leaflet, or a lot of times when that chordae tendineae, or those like little Purkinje fibers that are connected to our papillary muscles, get fibrotic, or if they have vegetation on them because of an endocarditis, or if we have ischemia to those little muscles and they're not able to pull like they're supposed to, is when we can have like some mitral regurg. These again can also just be from degenerative changes, as well as rheumatic heart disease, regurgitation, and Marfan syndrome, anything where our heart is too big because our valves aren't really going to grow. We're going to hear a systolic murmur with these patients. Okay, they might have some weakness, some fatigue, some shortness of breath. They might not have as much like activity tolerance as they used to. Maybe some signs of hypoxia, right, because they're sending part of their oxygenated blood back into their atria and not out their aorta and into their body. We also can have aortic regurg, which is kind of the same idea, right? Our aortic heart valve isn't closing all of the way. So during systole, we get some blood flowing out into our aorta, right, which is normal. But then during diastole, we don't close all the way. So some of that blood is going to come back into our left ventricle, right? It's going to backflow. Again, causes dilation of the aorta related to like hypertension, Marfan syndrome, inflammation of our leaflets from like rheumatic heart disease, or from endocarditis. They might be asymptomatic. We could also hear a murmur. And then this wide pulse pressure. And this wide pulse pressure is because we're having a lower diastolic pressure because this isn't closing all of the way. We can also have mitral valve prolapse. So this is when one of the leaflets actually go back into the atria. So they should open into the ventricle and then close, down into the ventricle and close. But this is going to go backwards. Okay, these are floppy flaps. They're not going to close all of the way. This can also be from genetic conditions, Marfan's, and then that MI as well, especially if we've lost those papillary muscles. If they've ruptured, we're going to kind of have that leaflet flopping all over the place. Stenosis, so valve stenosis, again, mitral and aortic is when we're going to have the most symptomatic patients. We can have stenosis and regurg on the right side of our heart, but generally it's less symptomatic because it's less pressure, and that's not the side that's perfusing our body, so we're going to have less symptoms. Stenosis is just obstruction because we have narrowing and calcification, thickening of those valves. Okay, in our mitral valve, it's generally going to be from an infection, where in our aorta, it's more of like a wear and tear, and just a result of years of calcium buildup from that mechanical stress of having to open and close all the time. Or with patients who have dyslipidemia or hypertension. So in stenosis, the opening between our leaflets, so say in our aortic valve we have 1, 2, oh, this is really bad, 3, okay, this is the whole valve, and if they're stenotic, this is how much they can open. So you can see there's just a little tiny opening for blood to get through instead of them being able to fold all the way to the side of the lumen of the valve. And same with like our mitral would be, if it's super fibrotic, this is when it's open, and it can only open so much because this is all fibrotic tissue, so we don't have a whole big outlet for blood. We can have valve replacements, right? Again, they're generally going to be our aortic valve or our mitral bicuspid valve, because that's when we're going to have the most symptoms. So this is a TAVR. So a TAVR is what they're able to actually do in like the cath lab, so they don't have to do surgery. So they go in and they can place one of these prosthetic valves. We have 2 different types of prosthetic valves. We have a mechanical, right? It's going to open and close just with pressure from your body. And then a biologic, which is generally either from a cow or from a pig. Okay, they last about 8 to 10 years. They don't really require long-term anticoagulation, generally like 3 months. Where the mechanicals, they last a lot longer, but you do have to have the anticoagulation. And then let's talk real quick on endocarditis. So endocarditis is inflammation of the lining within the heart. So this includes our valves, our papillae muscles, and then our chordae tendineae or our Purkinje fibers. It can be viral, it can be bacterial, or it can be from fungus. Okay, we see this in kiddos from like hand, foot, and mouth disease. And then we can see this a lot in our adults who have like implantable devices, so such as a valve or a pacemaker, dental procedures, poor oral care, and then also with like our IV drug users. Our bacteria tends to be like staph or strep, right? So even like an untreated strep throat can cause endocarditis. So our risk factors, I talked about those symptoms. Like these patients are going to be feverish, they're going to have flu-like symptoms. We can see some petechiae or like a little rash, like a palmar rash on their hands and at the bottom of their feet. And then they might develop a heart murmur as well, just from the vegetation on the leaflets not allowing the valves to close all of the way, so blood's able to move through incorrectly. And then they're also at a risk of a bacterial emboli, so they can actually launch one of those little vegetation balls up into like their brain or into their lungs, depending on where their endocarditis is. And then pericarditis, lastly, is inflammation of the lining of the outside of the heart. So this is going to be our pericardial sac becomes inflamed. Again, infection, most of the time pericarditis is viral, especially in kiddos with our Coxsackie virus, which is hand, foot, and mouth disease, some autoimmune disorders. You can develop pericarditis after an MI, after surgery, after trauma, from like the steering wheel hitting the chest wall really hard. It's normal to have an inflammatory response. It's just hard to have an inflammatory response in an area where you don't have a lot of wiggle room. So these patients are going to have symptoms of like chest pain. This chest pain is usually worse when they're laying flat. They feel a lot better like sitting up and almost tripoding. That chest pain goes away. Pain with inspiration, pain with coughing. You'll hear a friction rub on these patients. EKG changes, you're going to see diffuse T wave elevation. So that ST segment we had talked about will be elevated throughout the entire EKG because we have that inflammation. So that inflammation is going to change how electricity moves through the heart. Elevated inflammatory markers like our CRP will be high, procalcitonin will be high if it's a bacterial infection. Maybe lactic acid, our ESR, so our estimated SED rate will be elevated. And then we can see this on an echo. We can see that extra fluid. We can see the inflammation on an echo. For criteria, patients have to have 2 assessment findings. Management, we're going to do pain management, right? We generally treat them with NSAIDs because NSAIDs is going to reduce the inflammation, which is what's causing the pericarditis in the first place. And then anti-inflammatories such as colchicine, and then sometimes some corticosteroids. All right, any questions, let me know.